The following podcast is part of a certified educational activity titled Driven by Type 2 Inflammation, the Potential of Novel Biologic Therapies in Managing Chronic Rhinosinusitis with Nasal Polyps. Access the entire activity and complete the post-test at peerview.com/QJM860. Downloadable infographics are also available.
So we know that chronic sinusitis is very burdensome. It affects everyone's quality of life for those who have it. And the ones with nasal polyposis, their quality of life is much more severe and their symptom burdens are a lot higher. And it not only affects their quality of life, but it affects their productivity at work. And it is very common. It affects 3 to 7% of the U.S. population. And oftentimes, these patients with sinusitis, their symptoms are underdiagnosed and underappreciated. So chronic sinusitis is a catch-all term that talks about different types of sinusitis. But what's in common in these patients with chronic sinus is the duration of their symptoms. Usually they have to have symptoms for about 12 weeks. And the most common symptoms are postnasal drainage, nasal congestion, change in smell, and facial pressure. Now, in order to be diagnosed with chronic sinusitis, based on the American Academy, you have to have 2 of the 4 symptoms. One of the 5th symptoms that's probably underappreciated is difficulty with sleep. Not only do you have to have symptoms for the diagnosis of sinusitis, but you also should have an objective criteria, so whether it be with a nasal endoscopy or a CT scan. So when patients have symptoms of sinusitis, certain symptoms are more consistent with chronic sinusitis with nasal polyps, such as difficulty with smell or lots of smell and nasal congestion, while facial pressure is more suggestive of chronic sinusitis without nasal polyps. There are other symptoms that you can see in patients with sinusitis that are not so common, such as ear pain, sneezing, difficulty with sleeping, as we had discussed earlier. And if you have nasal polyposis, as we discussed earlier, your symptoms are going to be much worse. When you have chronic sinusitis with nasal polyposis, you often have other comorbidities that are associated with these nasal polyposis. And these are patients who often get acute exacerbations, they often have asthma or allergic rhinitis, and sometimes if the nasal congestion is severe enough, they can also have sleep disordered breathing or sleep apnea. Out of these comorbidities, the one that seems to be most associated with nasal polyposis is asthma. When you're examining these patients with nasal polyposis, it's best to do a nasal endoscopy. And I see nasal endoscopy as part of the physical exam. It's basically an extension of the physical examination where you can determine if there's nasal polyps, is there eosinophilic mucin, is there a deviated septum, is there a septal spur. Those are all things that are important in diagnosing patients with nasal polyposis. I think nasal endoscopy is very important because the nasal endoscopy provides one objective measure to look for patients with nasal polyps, purulence, eosinophilic mucin. Now, if you're trying to do an imaging study, the best imaging study would be a CT scan. And depending on if you're doing it for diagnostic or if you're going to use it for surgery, they have different protocols. But usually the CT scan is the best way to diagnose somebody with sinusitis and evaluate the extent of the disease. X-rays in general do not appear to be a very good imaging study for sinusitis. Using the objective measures, you can then understand the extensive nature of the disease process. And so in order to understand and try to personalize the treatment of sinusitis, endotype comes into play. Now, what exactly is endotype? And so endotypes are biomarkers that we can't necessarily see. These are things that, I perform in our laboratory settings, not available clinically. But what we can do is look at endotype and phenotype together, and based on tying the endotype and phenotype together, we can then look at the phenotype and indirectly have an appreciation of the endotype. For example, you can look at patients with asthma. As we talked about before, asthma is one of the comorbidities in patients with nasal polyposis. Now, if they have a high risk or the asthma is severe, you can kind of interpret that they're more likely to going to develop nasal polyps, while patients who don't have asthma are often less likely to develop nasal polyposis. In patients with sinusitis, we kind of break up them into two groups, chronic sinusitis with polyps and chronic sinusitis without polyps. And what we've seen in my thesis is when we were trying to subclassify the different groups of sinusitis, we found that chronic sinusitis without nasal polyps tend to have more of a Th1 or type 1 inflammation. And eosinophils do not seem to be a big role in these patients. And I would say majority of chronic sinusitis are chronic sinusitis without polyps. Now, about a quarter of the patients with sinusitis have nasal polyposis. Now, in these group of patients, they tend to have high tissue eosinophils and tend to have more of a Th2 inflammatory markers or type 2 inflammation. One of the things that we need to be very careful of, especially if they have asthma and bad nasal polyposis, is to ask their history about whether or not they've used NSAIDs. And if they have problems where they take NSAIDs and within 90 minutes they have difficulty with breathing through their lungs or have nasal congestion, you have to start thinking about aspirin triad or ARD. If you treat patients with chronic sinusitis, we know that it's a very difficult disease to manage. Often these patients have a chronic disease process where even the patients themselves don't even appreciate the severity of their symptoms. And these are patients that require multiple and long-term treatment, which may even include surgery. But the problem with these patients, especially the ones with nasal polyposis, is that even with surgery, it doesn't work. So you have to find some other medical treatments that you can use postoperatively. Oftentimes, these patients with nasal polyposis require systemic steroids. And if you do use it, you want to really minimize the use of them because they do have a lot of adverse effect. And because of that, a lot of people are using saline irrigation or mixing steroid into the saline irrigation and using it as a saline irrigation. People are starting to use steroid drops as another way. Now, in patients with nasal polyposis, antibiotics may not be the most effective treatment for these patients, but if they have an acute bacterial infection, certainly antibiotics is appropriate. Now, one of the things that we don't have a strong evidence for, but personally speaking, I do think that they work really well is leukotriene modifier. The leukotriene modifiers in certain disease processes, such as the ARD patients, are very important and very helpful, and that's a treatment that's often underappreciated among physicians. Now, when we talk about delivering topical steroids into our patients with nasal polyposis, we've been talking about steroid irrigation for many years. I remember our first publication in 2006 where we talked about budesonide irrigations, and it seemed to not only help their symptoms, but also helped objective measures such as nasal endoscopy, CT scans. Recently, there was a new device that releases steroids. These are steroid implants that you can put into the ethmoid cavities, and they release steroids over a period of 3 months. The two studies that looked at that was the Resolve studies, Resolve 1 and Resolve 2. Now, there is actually another way of delivering topical steroids for patients with nasal polyposis, and it's this exhalation delivery device. This is a device that is self-propelled through air coming through the mouth, going through the device, and then using the air, it delivers the topical steroids into the sinus cavities. And in this study, it shows that patients did get better and that their polyp score and that the symptom scores improved. Now, I would say if they fail medical treatment, and they usually include a certain amount of systemic steroids and topical steroids and maybe even antibiotics, if they fail that, we certainly talk to them about sinus surgery. When we talk about sinus surgery, we tell the patients that the reason why we're doing sinus surgery is multiple reasons. One, to decrease the inflammatory load of the patients. So whether that means removing the cystic leukotrienes or eosinophils. And another reason why we do sinus surgery is not only to just get rid of the inflammatory load and open up the sinus cavities, but we open up the sinus cavity so that we can deliver postoperative medication. And so this will usually include topical steroids. So as we have discussed before, patients with nasal polyposis, even after surgery, will continue to develop nasal polyposis. A lot of times, a lot of patients think that by doing surgery, you get cured of your nasal polyposis. That's not true. And there was a study by DeCond that looked at patients with nasal polyposis across multiple institutions. And what they showed that in these patients with nasal polyposis, even if they had sinus surgery and got postoperative medical treatment afterwards, 40% of these patients develop polyps again a year and a half later. And so that is very important for patients to understand, because a lot of the patients come in with nasal polyposis think that by doing sinus surgery, they get cured of their nasal polyps. Another way I kind of frame it to the patients is, if you do sinus surgery, does that cure you of your allergic rhinitis or asthma? No, it doesn't, because those are something that's more intrinsic to who the patient are, and you need to treat these disease process afterwards, even after surgery. And as we talked about before, we know that chronic sinusitis with nasal polyposis is driven by type 2 inflammation. So what does this mean when we talk about type 2 inflammation? So when we talk about type 2 inflammation, historically it was called Th2 inflammation, and part of it is because the T helper cells were mostly making the different cytokines such as IL-4, IL-5, and IL-13. And those are the different cytokines that are associated with type 2 inflammation. Now, the reason why we switched it from a Th2 inflammation to a type 2 inflammation is we're starting to realize that it wasn't just the T helper cells that are making these cytokines. We are noticing that other cells, such as ILC2 cells, are also involved with IL-4, IL-5, and IL-13. Now, when you look at IL-5 and you think about IL-5, IL-5 and eosinophils kind of go hand in hand. When you think about IL-4 and IL-13, you think about the atopic disease process. And when we think about IL-13, we think about goblet hyperplasia, tissue remodeling. So those are all the things that are associated with type 2 inflammation. Now, there are different reasons why people get nasal polyposis. We don't have a strong understanding of it, but one of the understandings may be that bacterial infections that cause biofilms is a reason for polyp formation. Another reason why we get formation is the inflammation and the destruction of the fibrin in the epithelium. Those are certainly different ideas on why and how nasal polyps get formed. We don't know yet, but we know certainly the things that can trigger it. So what we've said so far is that chronic sinusitis with nasal polyposis is driven by type 2 inflammation. So what we need to do is target these type 2 inflammation by looking at the type 2 cytokines. So you certainly have the anti-IL-5 monoclonal antibodies. So the different biologics that target IL-5 is mepolizumab, rezolizumab, and benralizumab. Now, benralizumab actually doesn't target the circulating IL-5. It blocks the IL-5 receptor. There's certainly omalizumab, which is another biologic, and we know IgE is very important in type 2 inflammation. So omalizumab targets the IgE. Now, the newest one that came into the market that targets the type 2 inflammation is Dupilumab. Now, Dupilumab is very interesting. By binding to the IL-4 alpha receptor, it not only blocks one type 2 cytokine, it blocks two. It blocks both IL-4 and IL-13. And it's very important to remember that you got to block both IL-4 and IL-13 together, because there were clinical studies that looked at blocking IL-4 by itself and it didn't meet primary endpoint. When you blocked IL-13 by itself, it didn't meet primary endpoint. But when you blocked IL-4 and IL-13 together, especially in our asthma patient, it seemed to be very effective. So again, you can't just block IL-4 or IL-13. You have to block IL-4 and IL-13 together. And we're able to do this with Dupilumab by binding to the IL-4 alpha receptor. So let's go into more detail about Dupilumab and look at the clinical study. As you know, this was recently approved for nasal polyposis in June of 2019. And as we talked about before, Dupilumab is a monoclonal antibody, it's an IgG4 monoclonal antibody that targets the IL-4 alpha receptor. And by doing that, it prevents the signaling of IL-4 and IL-13 together. There's two phase 3 data looking at Dupilumab for nasal polyposis. One is called Sinus 24, the other one is called Sinus 52. And so let's talk about Sinus 24 first. So here is a slide looking at the primary endpoints in nasal polyposis patients that were involved in the Sinus 24. What you saw here was looking at nasal polyp score and nasal congestion. And you see that with the introduction of Dupilumab, the study group that got the Dupilumab had dramatic improvement with the symptoms of nasal congestion as well as the nasal polyp score. When we think about placebo groups, we think of them as not getting any treatment at all, but that's not necessarily true in the study. In the Sinus 24 study, the placebo group actually got mometasone 2 sprays twice a day. So these were patients who were actually getting treated. And so when you compare the treatment group and the study group, you can see a remarkable difference in the polyp score. And at 6 months, you can see that the polyp size score between the treatment group and the study group was a difference of 2. And if you look at nasal congestion, you can also see there's a remarkable difference between the study group and the treatment group for nasal congestion. Now, what's interesting here is that these patients were getting Dupilumab for 24 weeks, and after that, it stopped. And then what you see is over a period of 2 or 3 months, the nasal congestion score starts increasing. So these patients are starting to get their symptoms again. And if you look at the nasal polyp score, it seems to parallel that of the symptoms where the polyp score starts to increase as well. So what that tells us is that Dupilumab, after a period of 6 months, probably does not have any sustained effect. And then after they're off the Dupilumab, their symptoms and their polyp score will come back. Now, these are some of the key secondary endpoints that we looked at in our study. And so in this study, you can see that there was a remarkable difference between the CT scores. So initially, these patients had complete opacification of the sinuses. In the treatment group, at 6 months, most of the sinuses were not opacified. And then when they were off the Dupilumab, their sinus cavities started to get opacified again. When we look at SNOT-22, which is not a great measure for sinusitis, but it's the most commonly used measure for sinusitis. It is probably the most commonly used quality of life measure for sinusitis. What you see is that there's a remarkable drop between the treatment group and the study group. And in fact, at week 24, the difference of the SNOT-22 between the baseline for the treatment group is a change of 3 MCID, meaning what is clinically meaningful. Because what is clinically meaningful in a SNOT-22 is about a change of 9. And what we also see in our patients with nasal polyposis, if you ask them what symptoms bother them the most when they have nasal polyposis, is their sense of smell and losing their sense of smell. And it's so bad, these patients are willing to take systemic steroids, 5 to 10 milligrams every day. And so these are basically steroid-dependent nasal polyposis patients. And in these patients, you can see that by giving them Dupilumab, we're able to improve their sense of smell dramatically across the different measures, whether it be looking at their daily loss of smell or their upset test. And then this is part of the Sinus 52. So remember we said there was 2 phase 3 studies. So Sinus 52 are patients who were given Dupilumab over a period of a year. And then at week 24, some of them were given Dupilumab every 2 weeks. Another group that were getting Dupilumab was given every 4 weeks. And what this Sinus 52 study shows is that they not only improved at week 24, but they continued to improve with the use of Dupilumab at week 52. And if you look at the 2 treatment groups, the ones who were getting every 2 weeks or every 4 weeks, there really wasn't a remarkable difference or a statistical difference between the group in terms of the nasal polyp score or the nasal congestion. What are other biologic studies that are being evaluated for nasal polyps? So we know Omalizumab had finished their study, and in their initial evaluation of their phase 3 data showed that Omalizumab improved nasal polyp score as well as the nasal congestion, so which is good. And it also seemed to improve some of the key secondary endpoints as well. Another biologic that looked at nasal polyposis is Benralizumab. Now, the initial phase 2 study showed that it did have improvement, and the other study is not done yet, and we're curious to see what it will show. Another one that just finished was looking at Dupilumab and nasal polyposis. So that just got done on October 24th. And so we'll see what the phase 3 data will show, and we'll see whether or not it was effective in treating our patients with nasal polyposis. And Rhinosinusitis is another monoclonal antibody that we've seen used in nasal polyposis. And so the way that Rhinosinusitis gets administered is through IV. Most of the monoclonal antibodies right now seem to be given through subcutaneous method, but Rhinosinusitis is the only one that is given intravenously. Now, there are other treatment options that are currently being evaluated. Some of the ones that people have talked about is looking at cyclic 8. Remember how we talked about how important the epithelium was in the type 2 inflammation? Well, one of the things that we should be looking at is some of the epithelial cytokines. And when we talk about epithelial cytokines, there are IL-25, TSLP, and IL-33. So there is one phase 2 study looking at IL-33. In fact, I suspect that there's more than one phase 2 studies looking at IL-33. What does this all mean? So we know that these biologics are effective in our patients with nasal polyposis. How do we start incorporating them into our practice? And I think, in order to incorporate them into our practice, one of the best ways is to have a team approach. So personally, as a otolaryngologist that also runs the allergy division, what I've been able to do is do a nasal endoscopy and biologic administration as a single individual. But most of the time, that's not the case. Otolaryngologists usually perform nasal endoscopy and are very comfortable, while allergists are more comfortable administering biologic. And so often one physician is not able to do both of them very well. So that's where the team approach is very important, where otolaryngologists are able to do nasal endoscopy, document that they have nasal polyposis, and then if they fail the typical treatment, then they send it to the allergist to have and work with the allergist to make sure that they're able to incorporate biologic therapy into our patients. What I've noticed personally is that, these patients that require biologics are often patients with severe nasal polyposis, such as patients with aspirin triad or ARD and EGPA or Church-Strauss. And oftentimes, when I usually incorporate biologics is usually after sinus surgery. What I like to do is do a sinus surgery, kind of debulk all the polyps, open up all the different sinus cavities so that if I need to include topical steroids in there, I can. And oftentimes, you can kind of predict ahead of time, whether or not they're going to have recurrence of the nasal polyps. Because if you start seeing polyps come back pretty quickly, that means they probably need something more than just topical steroids. And especially if the polyp starts coming back, even with the topical steroids, you definitely want to consider biologic in these patients. Basically, this is an exciting time for us as physicians who treat patients with nasal polyposis, because in the past, we would suffer, with our patients with nasal polyposis, because we would try to do everything possible, and there just wasn't a lot of treatment options. Now, lately, there's been a lot of good treatment options for our patients with nasal polyps. And, what's exciting is the introduction of biologic, because biologic is really a new class of treatment for our patients with nasal polyposis. So thank you very much for joining me in the CME activity.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/QJM860. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals.